Thank you for joining the Southeastern National Tuberculosis Center's webinar, When TB is the Least of Their Worries, TB and Corrections. The event will begin shortly. Please take this time to answer our Mentimeter question by going to menti.com and enter the code 115678. A direct link to vote has been shared with you in the Questions tab.
This is wonderful to see so many people. So many people are starting to give answers. That's great. Keep working on it.
While you all finish adding your responses to Mentimeter, I want to welcome you all to today's webinar entitled When TB is the Least of Their Worries, TB and Corrections, sponsored by the Southeastern National TB Center. This is the first webinar in the series. Before we start, I have a few housekeeping items. Today's webinar is scheduled for 1 hour, including the question and answer period at the end of the presentation. To verify your participation in this event, please make sure you enter the room with your first and last name, along with the email address you would like to use to receive the evaluation. A link to the online evaluation will be sent to your email within 24 hours. Please be aware that you must complete the online evaluation by 5 p.m. Eastern Time on Thursday, August 31st, if you want to receive nursing or physician credit. You have 1 week to complete this evaluation. You may submit questions for the speaker at any time during the presentation by typing your question in the Questions tab. Questions will be addressed at the end of the presentation. Thank you for joining us today.
Hi, everybody. This is Ellen Murray. Wow, there is a lot of things here on this Mentimeter slide, and I have to say every single one of them is true. There are so many. Discharge planning, there is no discharge planning. They have release planning. Lack of knowledge, communication, access, congregate setting. Just the fact that it's a congregate setting. Wow, this is amazing. You guys are dead spot on, spot on. Thanks. Keep them coming.
Today's speaker is Connie Haley. Dr. Connie Haley is an infectious disease adult physician and epidemiologist who currently works as medical consultant for SNTC. Dr. Haley received her medical training from Vanderbilt University, including specialization in internal medicine and infectious diseases, and a Master's of Public Health degree. She has a long history of working in the TB field, including serving 5 years as medical director of the Tuberculosis Elimination Program at the Tennessee Department of Health, 3 years as the director of tuberculosis research at TDOH, and 6 years as the principal investigator for the Tennessee site for the TB Epidemiology Studies Consortium. Dr. Haley is currently an adjunct professor of medicine in both the Division of Infectious Diseases and Global Medicine at the University of Florida and in the Division of Infectious Diseases in the Department of Medicine at Vanderbilt University. She enjoys collaborating closely with the Centers for Disease Control and Prevention and academic and public health partners across the U.S. to improve the clinical care of patients with tuberculosis and to advance progress towards TB elimination. Today's moderator is Dr. Ellen Murray. Ellen has her PhD in public health and has extensive experience in corrections and TB. She worked as a corrections nurse in jails for 17 years with expertise in infection control, risk management, and as an administrator, also working as a staff nurse. She also worked as a nurse consultant for the State Health Office in Florida for all the correctional facilities in Florida, which included Federal Bureau of Prisons facilities, state prisons, local jails, juvenile facilities, and an ICE facility for over 10 years before coming to SNTC. I will now turn over to our presenter, Dr. Connie Haley.
Hey, this is Donna. And real quick before you get started, Dr. Haley, I apologize, but we have a number of people who are concerned about getting their CEUs. You do not need to log in to anything today to get that. If you have signed in, if you have come in through the registration link, we have your email address and your name, and we will be sending you out an email within the next 24 hours with the evaluation link. Thank you. And with that, you can get started, Dr. Haley.
Thank you, Donna, and thank you, Linda, for such a nice opening. Can you hear me?
Yes, we can hear you.
Awesome. Okay. Welcome, everyone. I'm so glad to have all of you participating in this webinar. And I just wanted to give a disclaimer at the beginning that we may go a little bit over with our questions and answers. We're slated for an hour. This may go a bit over. We are recording this webinar, and so if you have to go back to your work, which is important, please know that you can tune back in another time at your convenience. And so I'm also going to try to go through a lot of material. There's just so much on this topic that I wanted to share, and hopefully it will be the right amount for this purpose. So this webinar and others in our series are designed as an opportunity to raise awareness about the persistent significance of TB as a global health threat, and also to explore how TB interacts with other medical and social conditions to cause significant morbidity and mortality. I wanted to, let me just get my controls. I wanted to show this headline that came out when the WHO released the last global TB report, as it recognized tuberculosis as the world's top cause of death from a single infectious agent, notably even surpassing HIV, AIDS, and malaria. TB is also now the 9th leading cause of death from any cause worldwide. The most recent studies indicate that at least a quarter of the world's inhabitants are infected with tuberculosis, meaning that nearly 2 billion people have the potential risk of developing TB at some point during their lives. The majority of TB disease occurs in low and middle income countries, as you can see on this map to the right. Besides residence or prolonged visits to these areas, the risk of exposure to TB is highest in congregate settings such as homeless shelters, long-term care facilities, and correctional facilities. Also, certain clinical conditions increase the risk of progressing from infection to active TB disease, including HIV and other immunosuppression, malnutrition and comorbid diseases such as diabetes and others, substance abuse, and smoking. However, given its transmission through airborne droplet nuclei, tuberculosis can affect anyone in any location, regardless of the socioeconomic status, their lifestyle, or their health. Notably, 1 in 3 people exposed to TB become infected, and fortunately, only a small proportion go on to develop TB disease, though you must know that the risk is substantially higher in HIV-infected persons. Now, this is a busy slide, but as you can see here, mortality associated with TB is substantial. And what I would like for you to keep in mind as you look at this graphic is that when you're evaluating individuals from other countries, whether it's in a correctional facility or in your public health department, consider that these people may not only have TB, but may also have HIV and drug resistance. And so take note of these countries listed here and realize that they are high-risk settings for HIV and drug-resistant TB as well. Patients with HIV have not only higher risk of developing TB once they're infected, but they also are much more challenging to diagnose and to treat. Similarly, the mortality associated with drug-resistant TB is higher, and patients will often experience significant adverse events or intolerance of the less effective second-line drugs that we have to use. And then last, I want you to realize that most deaths from TB could be prevented with early diagnosis and appropriate treatment. So shifting now to incarceration, on any day, the world's correctional facilities hold 8 to 10 million inmates. Given the high turnover in many facilities, especially jails and short-term detention facilities, 4 to 6 times this number pass through corrections each year. Globally, the incarceration rate incarceration disproportionately affects socioeconomically disadvantaged populations where the disease burden is high and access to medical care is limited. This typically includes individuals who are homeless, mentally ill, ethnic minorities and asylum seekers, immigrants, substance users, and other populations. So incarceration has a profound impact on public health, as most of you are aware. First, as we know, the incarcerated population is much more likely to be comprised of people who are low-income, medically underserved, with high rates of infectious diseases, physical diseases, and substance abuse, as well as mental health issues. Once incarcerated, individuals could also experience even more limited access to health care in some facilities, and this can lead to disease progression and worsened health outcomes. Additionally, inmates might be exposed to new health risks while incarcerated, such as high-risk sexual behaviors, whether voluntary or coerced. There's little access to condoms, and they may have shared needle use for drugs and tattooing. Of concern, about 50% of inmates meet the criteria for drug dependence or abuse, but only 15% of these individuals who need treatment actually receive it. And of note, many released inmates resume these risky behaviors at release, and in the first few weeks after release, the mortality is extremely high, as is the rate of recidivism. These health concerns thus cycle through the correctional system again and again, multiplying the impact on the inside and fueling the epidemics of HIV, viral hepatitis, and TB on the outside. Unfortunately, the United States has the dubious distinction of having the highest rate of incarceration in the world. It's more than 5 times the global average. 1% of the US population is currently incarcerated in some type of correctional facility, and given frequent turnover within this population, this means that about 10 million persons are incarcerated each year. The US rate of incarceration has dramatically increased since the 1970s as a result of the war on drugs and institutionalization of persons with mental illness. Incarceration rather than treatment of persons with addiction and mental illness, incarceration has been what they've used instead of treatment of these individuals with addiction and mental illness, whereas they should have hopefully been treated as chronic medical conditions. So this has really contributed, but has also disproportionately impacted low-income, predominantly non-white and medically underserved communities, as previously mentioned. On a positive note, I want to mention that US is making some improvement and the rate of incarceration is starting to decrease again. So this slide shows that shows the different types of correctional facilities in the United States. Our criminal justice system holds about 2.3 million people in over 1,700 state prisons, more than 100 federal prisons, more than 1,800 juvenile correctional facilities, more than 3,000 local jails, and 80 Indian County jails, as well as military prisons, immigration detention facilities, civil commitment centers, and others. So when you have time, you can come back and take a look at this and try to get more information on why, where different people are locked up and the reasons for their incarceration. I also wanted to show that not only does incarceration affect physical and mental health, but there's also profound civic and fiscal impact. After release, former prisoners and their dependents often remain locked in low socioeconomic status, unemployment, and in unstable housing. In most states, a prison record eliminates eligibility for public assistance, so they may not be able to receive food stamps, public housing, student loans, or even get a job. These factors, in turn, are also associated with low access to health care, higher disease rates, and worse health outcomes. So you can see that all of this works together to cause a really significant public health impact. So I've talked now about TB and corrections separately, but I want to show this slide, which depicts the global hotspots of TB in corrections. And you can see that the areas where TB prevalence is the highest in correctional facilities is the same as on the global map, looking particularly at East and Southern Africa, Southeast Asia. Please note that the white areas mean we just don't have any reported data, not that they have low incidence. One area that I think is particularly important to notice is the Eastern European area and areas in the former Soviet Union. Really high rates, not only of tuberculosis in correctional facilities, but also of drug-resistant tuberculosis. And so when you have individuals who report to you that they're from those countries and that they spent time in a correctional facility, it should raise your concern that they need to be screened and may benefit from preventive therapy. According to the WHO, the rate of TB in correctional facilities varies throughout the world, anywhere from 5 to 100 times higher than TB in the civilian population. And TB cases in corrections can account for 25% of a country's TB burden. Globally, up to 25% of cases in corrections are MDR TB, and this results from prisoners in many countries being allowed to self-treat because there's barriers to access to medical care, or they may have an erratic, unregulated TB drug supply, which is available through visitors or internal markets. Also, again, inadequate or inaccessible access to care can worsen outcomes and drug resistance. And again, this is a concern as it can spread outside the facilities to staff, visitors, and inadequately treated former inmates who are part of the surrounding community. So again, this is a busy slide, but I thought it was really nice depicting the various factors that fuel TB epidemics in prisons, inadequate policies and resources, health services within correctional systems, as well as treatment delays and interruptions, movement within the system, overcrowding, reincarceration, as well as the prison culture. There's an entire webinar that SMTC has done on this topic that we'll give you a reference to at the end of this talk. So again, all of these factors amplify the risk of TB in corrections and pose risk to the outside community. So shifting now to the United States, I think last year we were all glad that our TB case rate had dropped down to just over 9,000 TB cases, but unfortunately this is still remaining way too high. We're still 28 times the threshold of the needed 1 case per million to be able to consider the US as having eliminated tuberculosis. And notably, our non-US born rate is much, much higher than the US born rate. And you can see that on this figure here over to the right. There are also other disparities, TB disproportionately affecting minorities and other populations in the United States. Interestingly, 4 to 6% of TB cases that are reported in the United States are incarcerated at diagnosis. And as you can see from this bottom figure, while total US cases have decreased, correctional cases decreased some, but they've started to level off. And so we've still got a number of cases occurring in correctional facilities. This continues to be a source of TB transmission to the community that we need to start focusing on. And many of these patients, just as in the general epidemiology of the United States, are non-US born. They also have challenges such as excess alcohol use, injection drug use, and non-injection drug use. So in the United States, there has been well-documented transmission of TB from inmates to correctional staff, as well as healthcare workers in the facilities, and also healthcare workers at community sites they may be transferred to, such as local hospitals or long-term care facilities. As well, there's documented transmission to family members and other social contacts that can occur during prison visits or after the inmate has been released. And I'm listing here some publications that you may find of interest and referred to. So while correctional facilities are a source of concern, I want you guys to recognize that they're also an opportunity for prevention. And effective TB control in correctional facilities protects not only inmates, staff, and visitors, but also can be really useful for protecting the health of the public at large. And to prevent TB in correctional settings, there is a comprehensive package of measures that are typically required. I'm not going to cover all of these, and I want to shift the remainder of this webinar so that we really focus on issues as they relate to the clinical care of persons diagnosed with or treated for TB while incarcerated. There's other publications where you can get more information on infection control and other programmatic issues, and we have references at the bottom of the slides and also at the end of the webinar and on our handout. So I want to go ahead and give you a presentation of a patient that I became involved in as a medical consultant for SNTC, because I think this case highlights challenges of TB in corrections, a number of which you guys aptly recognized when we were doing the Mentimeter exercise at the beginning of the presentation. So this patient was a 22-year-old African-American male. He was incarcerated for committing a violent crime and had a history of having had underdeveloped lungs from birth, but he was otherwise healthy. He was a 6-foot tall man of slender build, and on April 2014, he underwent new intake into the prison system from his county jail. So I want to take a minute to get some audience participation for this polling question. Linda, if you could put it up for me. So the question is, how should inmates be screened for TB disease or infection at intake into corrections? The choices are TB symptom screen if they're incarcerated for more than a month, TB symptom screen at intake, regardless of the time they've been incarcerated, skin test or IGRA at intake, chest radiograph at intake, or with no resources for screening, just pray constantly. And that's probably needed with any of those responses. So go ahead and fill out your responses. I can see that about 35% of people have voted. It seems that most people favor the second and third options, that TB symptom screening should be done at intake, and also that skin test or IGRAs should be done at intake. And so great job. We've had a really strong response. So I'm going to go ahead and ask you to close that question out, Linda, and going to move on with the presentation. Thank you. So I'm going to get to the answer, but I want to talk generally about TB screening in correctional facilities, or really even elsewhere. There are two primary reasons that we do screening for tuberculosis. The first is early identification and successful treatment of people with TB, and this is the most effective means of preventing TB transmission. Particularly in correctional settings, individuals who are likely to have infectious TB, once they're detected, can be isolated and started on treatment before they're put in with other people, or in this setting, in other inmates. The other benefit of screening programs in high-risk settings like correctional facilities is to detect people who have TB infection and are not yet sick with disease, because they'll benefit from therapy to prevent them from becoming sick and transmitting TB to others. And in the United States, this treatment of tuberculosis infection in correctional settings is considered a public health priority, and so really important for all of us to be participating in. The type of screening activity that's conducted in a correctional setting depends on a number of different factors, including the type of facility, how much TB disease or infection has been detected in the facility and the surrounding community, the inmate's length of stay, and other factors. So details about how you conduct screening in correctional settings can be found in the references at the bottom of this slide, and you're welcome to call us afterwards as well. We can help with any questions you might have. But I want to say that the answer to our polling question was number 2, that all inmates should be screened for symptoms of active TB disease, regardless of the facility, regardless of their risk. That is the way that we detect active TB cases, because as you know, the skin test and the IGRA can have false negatives in individuals who are actively sick with TB disease or have other conditions that might cause them to be immunosuppressed, such as HIV. It's also important that we ask inmates about their history of TB or their history of TB exposure, as well as whether they've had TB treatment or LTBI treatment in the past. In addition to symptom screening, skin tests and IGRAs are very important, valuable tools that are used in most correctional facilities, but may not be used in all jail settings for inmates who may be only in the jail for a really short period of time. Chest X-ray screening also has some benefits, primarily to detect active tuberculosis in high-risk settings, such as jails where there's a lot of ongoing TB transmission. But chest X-rays alone cannot detect the risk of TB infection, and so usually they're good for active case finding, but not as much for individuals who would benefit from prevention. As to the question of when screening occurs, it should be done before entry or right at entry into correctional facilities, but it's also done on an ongoing basis once inmates have been admitted. Usually it's done annually, but if there's an outbreak or TB transmission going on, or if it's just known to be a high-risk setting, it may be done more often. Case detection is also important, keeping an eye out for anything that suggests a person, inmate or worker in a correctional facility may have active TB disease, and inmates who come to the medical system complaining of typical symptoms suggestive of TB should be a high suspicion in that population as well. And of course, you all are familiar that contact investigations are a way that we detect individuals who have been recently infected and would benefit from therapy to prevent active TB, but also we may find cases of active TB that have already developed since the initial exposure. So I want to just talk briefly. You're probably all familiar with both the skin test and the IGRAs as the tools that we use to detect TB infection. I want to mention that neither is a gold standard, and both have limitations that are described elsewhere. But it is important that we know that both of these tests, while they can be really helpful in detecting TB infection, they cannot distinguish infection from active disease, and they're also potentially false negatives, so that if they're negative, it doesn't fully rule out the presence of infection or disease. And it's also important to always consider those testing results in the context of the patient that you're evaluating, looking at their risk factors and exposures, their clinical evaluation for signs and symptoms, their other lab results, including HIV test, radiographic studies. Chest X-ray is required to consider a patient having not had active TB because a chest X-ray rules out pulmonary disease, and then other evaluation that makes sure that active disease is not present. So TB infection is really a disease of exclusion. So this figure is a little complex. It took me a while to get used to it, but it's from the 2017 ATS CDC IDSA TB diagnosis guidelines. And it shows the recommended paradigm for evaluating people with TB infection based on their risk of infection, their risk of progression to active TB, and the benefits of therapy. Step 1 is to look at the risk of infection as being likely or unlikely, and step 2 determines the risk of disease progression being low, intermediate, or high. And as you can see here in step 1, down here in this red box, residents and employees of high-risk congregate settings fall into this group of individuals likely to be infected, and also those who would benefit from therapy. The majority of inmates probably have either low or intermediate risk of developing TB once infected. Intermediate risk would include things like diabetes, renal failure, and IV drug use. High risk would be people who have HIV infection or other immunosuppressive therapy, abnormal chest X-ray, consistent with past TB or silicosis. And so, again, low and intermediate individuals would fall into this yellow box, and the high-risk individuals would fall into this orange box. So moving on to the next slide, that's also part of the guidelines. When you have groups that are likely to be infected with low to intermediate risk of infection, as shown here in yellow, the preferred test is the IGRA where it's available, but it is acceptable to also use a skin test. If you have individuals who are born in other countries and may have BCG vaccine in the past, or those who, then the IGRA is preferred. If you have individuals who have a high risk of active TB disease progression, such as HIV, then, or young children, and they would fall into this orange box, and either test is considered acceptable. There are several publications that look at the use of IGRAs for screening in correctional facilities, and unfortunately I don't have time to review all of these, but I did want to provide some references for you to review at your own time. And I also wanted to be sure and remind everyone that CDC recommends HIV screening for everyone in all healthcare settings. Inmates have a very high risk of HIV in addition to TB, and so it's very important that this population be evaluated and tested for HIV, and in particular, individuals who have active TB disease or latent infection. So back to our patient. So this patient actually was not screened in his local jail with a skin test or IGRA. Hopefully he was screened for symptoms. That wasn't documented. But when he came in at intake, he had a 0 millimeter skin test. And I do want to commend the people taking care of this patient for documenting this as 0 millimeters with an objective reading rather than just putting negative, because negative, is harder to interpret. It also makes it difficult if the patient has an increase in the size of their induration later to try to determine exactly what that change is. So anyway, he was admitted and transferred to the outlying correctional institution and received a second stat skin test, which was also 0. And the next day after injury, he went to sick call complaining of a nosebleed when he was hot. And he had a weight of 145 and was otherwise had unremarkable vital signs. And so he was probably treated symptomatically and sent back out into population. A couple of months later, he signed up for sick call but didn't show back up. And then he came back in about 6 months later, complaining of a bad cold with cough, being stopped up, and having a runny nose. At this point, although his weight was down quite a bit, as you can see, almost 30 pounds, his symptoms seemed to be fairly mild, and he was assessed as having, just a regular cold, treated symptomatically and sent back out. He signed back up for sick call in a couple of days, but he didn't show back up. So in mid-January, he presented again to sick call, and at this point he was fairly ill. He was losing weight, he was complaining of fever. He said he'd been sick for several weeks but had no other symptoms. He had a documented fever at this point of almost 102, and he was pretty tachycardic. And at this point, his weight had continued to drop, and he was at 113 pounds. He was mildly anemic, had just a mildly elevated AST and a high C-reactive protein, but was otherwise, his labs were fairly unremarkable. Because sometimes inmates will complain and seek care, there's lots of different reasons why individuals might come in, and so they're not always taken seriously initially. And in addition to that, a flu outbreak was occurring at institution, and it was felt that he probably had the flu, and he was again treated symptomatically. He was followed up every day that week and did have a couple of days where he had a fever. But finally, on the 22nd, he came back into sick call and was really feeling bad. And it was then recognized that he actually lost 40 pounds over 6 months and that he was quite ill. And so at this point, he was admitted to the prison infirmary, again with fever and tachycardia, and a chest x-ray was done. The chest x-ray was pretty remarkable, and I think the medical staff were surprised by how severe the findings were. He had diffuse nodular alveolar infiltrates throughout most of his right lung, extensive bullous changes in blebs in the mid and upper lungs, as well as infiltrates and possibly an effusion. But the impression from the radiologist really led the team to think about this patient who's young and otherwise healthy as possibly having sarcoid. And so, unfortunately, the medical staff kind of went with that. There was one TB infection control coordinator who was very concerned. She had been to the SNCC TB and corrections training course, and she actually was really closely linked with public health team. And she said, I think we ought to think about TB. Let's get another skin test. So they reluctantly did that. and it was still negative at 0 millimeters. So he remained quite sick, and ultimately, a couple of days later, got a CT chest, and again, very advanced disease. He had lymphadenopathy, a lot of nodules, consolidation, findings suggestive of chronic disease like bronchiectasis and cavities. And again, the radiologist was really leaning towards sarcoidosis as the etiology, but fortunately did also mention miliary TB. At this time, HIV was negative, and the infection control coordinator again really said, okay, I know the skin test is negative, but they can be negative in patients with active disease, so let's get a quantiferon too. So that was done, and it was reported back as positive. Unfortunately, I don't have the quantitative values for the quantiferon test. I think that's usually very important to review when we're trying to interpret the results, but I don't have it in this patient. So that same day, the infection control coordinator actually went personally over to the public health department, TB control, and reported this patient in person. And so that was an excellent way to raise attention about this and begin the collaboration between public health and corrections. I noticed as I was reviewing the chart that this patient was also started on Levaquin right away. And I just wanted to mention that we see this all the time in the community as well as in corrections. And it can be very unfortunate because Levaquin and moxifloxacin as well have very good activity against tuberculosis. And so patients who might get this before the diagnosis of TB is made could end up having delayed diagnosis. They might even respond a little bit to the Levaquin. But because these drugs don't treat TB alone as monotherapy, patients often end up getting worse again down the road after a longer period of delay, and you can even develop quinolone resistance. I also saw that this patient was started on prednisone before TB therapy was started, and I'm not really sure why. I did see that there was some use of albuterol and other pulmonary type medications, and so it's possible they were concerned about him having some reactive airways and dyspnea, but just wanted to say that typically we don't treat pulmonary TB with prednisone or other types of steroids because there's not good evidence that it helps unless the patient is severely ill and really circling the drain. We do use steroids for patients with TB meningitis, however, and that information is in the guidelines you can read on your own. So I wanted to go into the types of clinical samples that should be obtained when you're suspecting tuberculosis. And so this is straight from the new guidelines that were put out in 2016. And my point is that in corrections, or even in the community, we can certainly diagnose TB on a clinical basis without confirmed testing. But that really hinders us because without a positive test that says it's definitively TB, and without a culture that allows us to have drug susceptibility testing, we really will not have enough information to manage the patients appropriately. And so I really wanted to encourage those of you who take care of patients in correctional facilities and those in public health working to support those taking care of patients in correctional facilities, please pursue the diagnosis and try to get a confirmed sample. The guidelines say that if a patient cannot produce a natural sputum, or if a natural sputum is AFB smear negative and you strongly suspect TB, go ahead and get sputum induction. And this can be done obviously in a negative airway room, a negative pressure room, or airborne infection isolation room. But if you don't have such a thing at your facility, you can actually go outside and do sputum induction outside in the open air with little risk to staff as long as they're wearing a mask. Also, respiratory samples can't be obtained from induced sputum. The patient's just really dry. It's recommended that you pursue it all the way to a bronchoscopy. And that bronchoscopic sampling allows you to get a specimen, hopefully a positive culture that you can then get susceptibility testing on. And then finally, if bronchoscopy is done, the post-bronchoscopy sputum specimen is actually a very high yield specimen that helps confirm the diagnosis. And so be sure if you're sending your patient off for bronchoscopy that you also ask them to get a post-bronchoscopy sputum sample to do AFB smear and culture. And the other thing I want to highlight is in the guidelines really focuses on bacteriologic examination and the fact that we can now make diagnosis of TB using rapid molecular diagnostics within even just a day. So the smear, of course, we can get usually back in a day, but also CDC recommends that every patient who has a sputum sample collected, if there's AFB smear positive and if TB is suspected and they're AFB smear negative, should undergo nucleic acid amplification tests, and that's called a NAT or a PCR. Gene Expert and the Hind test are certain types of nucleic acid amplification tests, and they actually also can tell you whether or not there is drug resistance to rifampin. And in the case of the Hind test, it can show rifampin and INH. And so most state labs can do the Gene Expert test, and corrections can coordinate with the state labs to get that done. At the University of Florida and in the state of Florida, we actually use the Hind test, and we can help you with that if that's beneficial to you and your lab can't get it. So I want to move to my second polling question, and Linda, if you don't mind going ahead and putting it up. This patient's AFB smear came back 4+ positive, and that suggests that he was had a high burden of disease. It's not surprising based on the CT scan that we saw, including big cavities. And also his NAT was positive for M. tuberculosis. So we know now that he's a confirmed TB case. And so my question is, what should we do next? First response is to isolate in the infirmary and begin TB therapy. The other would be transfer him to a hospital for isolation and begin therapy. Third choice is to isolate, get a Gene Expert, and start appropriate TB therapy. Fourth choice, wait for culture results to isolate and begin therapy. And last, release into the community and let public health decide. And I know that last choice might be really tempting in some settings. And there's probably some of you listening on this call who've had that happen. But again, most correctional facilities have the capability of evaluating patients. And I can see here from the poll that the majority of people want to either isolate the patient in the infirmary of the prison and begin TB therapy, or to isolate, get the Gene Expert, and then start therapy once drug resistance has been ruled out. I think those are both good choices. Also want to consider whether or not the prison infirmary has an airborne infection respiratory room where they can be isolated appropriately. And if they don't, then you would need to move that patient out to a hospital where they can be put in appropriate airborne isolation until they're non-infectious, when they can be sent back to the prison setting. So great job, you guys are all doing fantastic. It looks like we've got a lot of knowledge in this group of participants. So I'm going to shift now to talk a little bit about TB treatment. The new TB guidelines have been out for a couple of years, and there's a lot of other places you can go to get a detailed overview on this topic. But I want to highlight that in a correctional setting, the treatment of active TB disease is exactly the same as it would be in a community setting. And as you know, there are 4 treatment regimens listed here, 1 through 4. 3 of these 4, regimens 1, 2, and 3, start with daily therapy during the intensive phase for at least 2 weeks. And with regimens 1 and 2, daily therapy is used for the entire 8-week duration. And at which point therapy can either be continued daily for the duration of TB treatment during the continuation phase, or it can be moved to an intermittent regimen 3 times weekly, which I think is used more often in public health now than twice weekly therapy. Regimen 4 is the old Denver regimen, where twice weekly therapy is used for the last 6 weeks of the intensive phase and the duration of the continuation phase. This is certainly something that we used for many years and had very good outcomes with. The concern would be if patients miss a dose, they miss half a week of therapy. And in a correctional setting, I think it's typically feasible to do either daily or 3 times weekly therapy. So I would recommend regimens 1 and 2. In a correctional setting, I don't think there's many patients that I would put on 3-time weekly therapy, this regimen number 3 here, during incarceration. I think that daily therapy or 3 times a week is better. And I also want to say that for patients with HIV, daily therapy at least for the initial 2 months, is recommended, and highly intermittent therapy is not recommended. So 3 times a week or daily therapy is what's preferred. And certainly if you have HIV or drug resistance, you should contact your public health program or one of the centers of excellence, such as the SNTC, and we can help you manage those patients. A lot of factors can increase the risk of adverse events during TB therapy, whether it's in the community or in correctional settings. I have those listed here, and I just want to say that I'm not going to go into a lot of detail here because other webinars in this series are really going to focus on things like diabetes, HIV, hepatitis, substance abuse, and mental health challenges. I will say, though, that I look up all of my patients' medications to make sure that I have appropriately looked for drug interactions, and I would encourage you to do that as well. So going back to this patient, he was started on standard 4-drug therapy with rifampin, isoniazid, PZA, and ethambutol. And remember, his weight was quite low, and so this low dose of ethambutol may have been appropriate for him. But he really didn't respond to therapy as they were expecting. His culture did ultimately come back positive, and because he was really not feeling much better, radiology was repeated, and it appeared to be continually worsening, as was his symptoms. He continued to have positive cultures as well, and finally, towards the end of February, for about 6 weeks, he was hospitalized at a local teaching hospital. During this time, his medications came back as being pan-susceptible to his first-line TB drugs, and so PZA and ethambutol were stopped, although I do want to note that he did not get the full recommended 8 weeks of therapy, even though the correctional facility had planned on doing this had he stayed in their facility. So he was basically on INH and rifampin during the hospitalization, and therapeutic drug monitoring was obtained to check why he might be not responding, and that's appropriate because, as you all know, when we think about patients who are slow to respond, we think about non-adherence, which seems less likely when a patient is getting DOT, hopefully, which was what he was getting in prison, and also malabsorption. And so looking at the drug levels is really helpful for both of those things. So when the drug levels came back low, he was put on IV daily medications of rifampin and INH. And one other comment is that his levels were sent to an outside lab and not to University of Florida or National Jewish or one of the recommended places that have really validated this technology. Most reference labs don't know how to do this appropriately, and so I would recommend if you're going to obtain therapeutic drug monitoring, you go to one of the labs that we use in public health. So he got a little bit better while he was on the IV meds and was ultimately sent back to his correctional facility. His smears and his cultures were positive, though, throughout April, and he really started getting worse again. He had further evaluation, and again, his radiology appeared to be not improving and maybe even worsening, and so there was also concern that he might have developed a renal abscess on an ultrasound, and so he was readmitted to the hospital. Towards the end of that hospitalization, they ended up restarting 5 drugs because he was still smear positive, and so they put him back on PZA and ethambutol, as well as moxifloxacin, rifampin, and INH IV. At this point, I think they were really not sure what was going on with him. So we were contacted, and this is the point where Ellen and I got involved with this. And, we reviewed what we were given, and we agreed that it's important to repeat cultures to make sure you hadn't developed any acquired drug resistance and to repeat the drug susceptibility. You all are probably aware that after, if you want to get a follow-up drug susceptibility test after the initial one, you really need to ask for it because the lab will automatically assume that it's been done before, and so they won't repeat it unless you ask specifically for that. And that's, again, where public health can work with corrections to make sure that the right tests are ordered. We noted that PZA had not been given appropriately, and so we recommended they restarted therapy from the beginning and make sure that he gets 8 weeks of PZA. We recalculated the doses for his current weight, and we looked through his MAR to find any kind of drug interactions that might be affecting his drug levels, and also to make sure he wasn't getting antacids or other things that could be preventing absorption of his medications. We felt that quinolones were probably not needed, and also we felt that we had no reason to think he couldn't absorb meds, and so oral was recommended instead of IV drugs. We recommended daily DOT with drug levels at the fifth dose, and we encouraged them to keep a chart of the smears and cultures because it was hard to figure out exactly what therapy he'd gotten and what his lab results were. And the thing that we really felt was the most needed was to talk very carefully to all of the staff giving DOT and make sure that it's not just giving them the pill and sending them back to their cell, but making sure that he understood it was directly observed swallowing, so that whoever gave the DOT checked his mouth afterwards with a flashlight, gave some water, and even had him sit there and wait. And talk about, we also recommended patient education and exploring things that might be contributing to possible non-adherence. So about this time, the therapeutic drug levels came back, and again, indeed, he was negative, and appearing that he either was completely not absorbing, but more likely we felt like he probably just wasn't taking his medications and somehow was surreptitiously avoiding his medications, even though the staff kept saying he was definitely getting DOT. And it turns out that as this was coming up, the correctional team was sitting around talking about him. And as they got these levels and looked at it, one of the nurses said, you know, come to think of it, I don't think this patient's urine is orange. And so, as you know, patients who are taking rifampin will have discoloration of their urine and other body fluids. And when you don't see that, that's a pretty good indication that this patient may not be taking their medication. And so, indeed, they asked this patient, hey, you know, your drug levels are low and your urine's normal. What's going on? And he admitted then they actually had been cheeking the meds for the whole time that he'd been on TB therapy, and that was why he was not getting better. And so unfortunately, that meant that a lot of time and money had been spent trying to figure out what was going on with him when non-adherence was really the issue. And we see this in public health as well as corrections. This is definitely not pointing fingers at the correctional setting. We get this out in the general public as well. But just to say that DOT, no matter how much we think we're doing it the right way, patients can be clever, and we don't really know why some patients might be doing something like this. He was clearly really, really sick, and you know, they asked him later, you know, why were you doing that? And he said, you know, I just couldn't think straight. You know, I was afraid. I really didn't understand what TB was or what the medications were. I really didn't know what to do. Once they realized he was not adherent, the staff actually had him sit right outside the infirmary, made sure there was no trash can or anything else near him, and made him sit there in the hallway with a mask on right by the nurse's desk for at least an hour after DOT was given. And sure enough, within a few weeks, he was feeling so much better. He began to laugh and joke around and really just look so much better. And he began to gain weight, and he ultimately completely improved. And I just want to say I'm just amazed and in awe of how hard both the prison staff and the TB control staff in the community worked for this patient. They went above and beyond working with him, trying to get him to eat before they even knew what was going on, trying to find out why he was so ill and help him. And, you know, there was a huge effort made to get him special treats that he wanted. There was a lot of communication between public health and corrections. And I just think they did a great job with a really complicated patient. And so this is just a good lesson that non-adherence, as you guys said on the Mentimeter, can really be a significant problem, especially in a correctional setting. Wanted to highlight that when they did the contact investigation for him, he actually, unfortunately, had moved around quite a bit. There were other inmates who had been exposed to him that had also moved around. He was sleeping in an open bay, which looks somewhat like this picture I'm showing you here on the right. It's actually not him or his prison. It's just a picture I found. He also worked in the cafeteria and had been released to court as a witness. And so there was a lot of exposure to other individuals. It was a big, complicated contact investigation. And they had to actually move the statewide annual Department of Corrections testing up so that they could just do the entire system to make sure they got everybody. And they did find 8 inmates who were skin test converters, including one who already had active TB disease. Fortunately, no staff converted. And then ultimately, when genotyping came back, they found that he actually matched 6 other individuals in the community where he came from. And so he was infected before incarceration, but brought it into the system and transmitted TB within, which is kind of what we've been talking about. So I want to move now. I'm going to kind of move on. We've talked a lot about factors influencing treatment interruptions. You guys can come back to that, but I want to focus on how important TB case management is in correctional facilities and making sure that treatment completion is achieved even after release, and usually may involve trying to address comorbid conditions, substance abuse, mental health, social issues, with a lot of counseling and individual identification of barriers. In particular, when you have immigration and customs detainees, be aware that this population is particularly hard to get to complete therapy given their mobility and other problems like that. And so there's organizations that can help you with continuity of care, including Cure TB and TBNet. And so reach out to your between corrections and public health department and bring Cure TB and TBNet into your case management so they can help you with continuity if that individual leaves the country. So I want to move on now to the treatment of contacts and how do you treat LTBI in a correctional facility. I think given the time, I'm going to skip this polling question, Linda. So, but I wanted to go ahead and talk about the importance of addressing TB infection in correctionals. As I've said, this important part of infection control in a prison setting and public health in general, because treatment of TB infection substantially reduces the likelihood that a person who has infection will go on to develop active TB at some point in the future, especially patients who have immunosuppression and HIV. Of note, the U.S. Preventive Services Task Force recommends TB testing for high-risk individuals, and this includes individuals in congregate settings such as correctional facilities, and treatment of TB or TB infection should be provided when infection is found, as long as there's no contraindications. And you can go to this reference at the bottom of this slide if you want to see the Preventive Service Task Force guidelines. So this is just recently released information on the treatment of TB infection from CDC. The web page link is right here for you. INH is still recommended for 9 months, preferably. It can also be given for 6 months. But now the focus is really shifting more firmly in the direction of using shorter rifampin-based therapy, such as rifampin monotherapy for 4 months and isoniazid and rifapentine for 3 months. Once weekly, which is also called 3HP. The newest guidelines based on a really nice systemic review show that this regimen of 3HP can be used all the way down to the age of 2, can also be used in individuals who have HIV and AIDS as long as you're careful about drug interactions with rifapentine. There's not good data, though, for pregnant women, or it should not be used with patients with drug resistance. There's also been a recent randomized clinical trial published on the benefits of rifampin, and I'll just say that both of these regimens have been shown to be equally effective to isoniazid, but associated with less hepatotoxicity, less intolerance and other side effects by patients, and a much higher treatment completion rate. And the effectiveness of LTBI therapy is nothing if you can't get the patients to take the full course of treatment. And so would recommend that you shift over in your general practice as well as correctional facilities to using the rifampin-based regimens as you can. And there is actually some literature that supports this. There's a couple of publications I'm listing here about the use of 4 months of rifampin. The only thing against rifampin daily is that, again, it's not self-observed in a correctional setting. That could be a challenge. And as long as TB is fully ruled out and you're absolutely certain there's no active TB, rifampin is an appropriate regimen. If someone inadvertently had not fully ruled out active TB, ignored symptoms of TB or setting like a high-risk factor like HIV, then rifampin could be a problem. And also, rifampin has a lot of drug interactions. 3 months weekly INH and rifapentine has been recommended and is used in correctional settings and is, I believe, actually used now as a recommended treatment course for the Federal Bureau of Prisons. But there are a couple of, you can refer to these publications and get some details here. The new guidelines do mention that self-administered therapy is possible for some patients who are given the 3-HP regimen. And I'd just like to say the guidelines don't mention at all whether or not this should be done in corrections. Hopefully this will come out eventually, but I personally, and I've talked about this with my colleagues at SNTC, I personally feel that people who are incarcerated and have all these other issues going on are probably not an appropriate group to use self-administered 3-HP on. Missing a dose of weekly therapy is a substantial proportion of the therapy, and hopefully these individuals can be given DOT while they're incarcerated. So I would not recommend using self-administered. I would recommend continuing using directly observed therapy if you choose to use 3-HP. And then last, I want to highlight that, again, not only is TB in corrections a big problem, but doing screening and providing treatment for TB and LTBI is really an opportunity. It's an opportunity to improve individual as well as public health. It may be a lot more challenging at release to find high-risk individuals, and so collaboration between public health and corrections is very, very important. And so I'm going to turn it over now. I know it was a lot of information, and we're going to jump into some questions. But I'm going to turn it over to my colleague, Ellen Murray, as you all know, is the TB corrections guru. I'm going to let her just briefly mention our TB corrections toolkit and let her help me go through some of the questions you guys may have provided. If you haven't provided questions yet, go ahead and put them in, and we will be glad to answer them for you. So with that, Ellen, you are on.
Thank you, Dr. Haley. Excellent presentation, as always. The Corrections Toolkit is on our SNTC website, and the toolkit we've developed for people in corrections and also for people in public health who may be working with their correctional facility, but it's geared towards a patient in a correctional setting. In the general information, we have how to get into a correction setting. And in TB screening, we have a risk assessment. We have several other forms, and we're in the process of finalizing some videos to go with those forms so that it gives you some little tidbits here, there, and everywhere. Case management, again, same things, a clinical pathway, other things that will assist you out in the public health areas when you're thinking about corrections. And these are specific to corrections. Things like with a case management, don't forget, talk to custody to find out this is somebody you want to know when he's getting released or transferred, or if he's getting sentenced, because you want to know where he's going. And it reminds you to ask those questions, and they will actually give some of that information to you. Contact investigation, same thing, a lot of different forms that will help you when you're doing a huge contact investigation. As opposed to 10 contacts in corrections, you'll have probably hundreds of contacts. And so it becomes a big, big challenge just trying to get all the numbers together and all the forms together. So we've tried to make that as concise as possible. We have environmental control forms to help you check negative pressure and how to look at the negative pressure cells and how to actually do that screening to make sure that that cell is actually working and it's negative. Release planning, we've got a lot of tidbits on how to begin developing a release plan with your correctional setting and your custody folks as well. And we actually have a course just for contact investigation and release planning to help people get together and try to merge that. We have some legal forms. We have a lot of evaluation forms, and of course, there's always training. We do have one question that came in, and Dr. Haley, please jump in at any time, but the question was, why didn't they do sputum on this patient? And with this particular patient, they weren't immediately thinking TB. They finally did a sputum, and the first one was negative, probably because it was after the Levaquin. But subsequent sputa were positive, as you saw on that slide, 4+, and culture positive. Am I correct, Dr. Haley? You want to comment on that?
Yeah, you're right. Again, similar to all of the Mentimeter responses that our audience provided at the very beginning of this presentation, they weren't thinking about TB in him initially, and so sputums weren't obtained until he became really super ill, and the infection control coordinator was really jumping up and down saying, I know this can test negative, but I still think this could be TB, and we really need to. She was really pushing for it, which again, I just want to commend that bravery, because I think she was alone in that initially. And then, as you mentioned, yes, that he was ultimately smear positive, also nucleic acid amplification test positive, and then culture positive. And I don't, Ellen, I don't see other questions. Do you want to talk a little bit about some of the things that you've done a lot with culture and corrections? Do you want to talk a little bit about some of the Mentimeter type responses that affect delay in diagnosis, and whether inmate factors, facility factors, and that kind of thing?
Connie, we actually have 2 more questions.
Oh, okay.
Like 3 more questions. Yes.
Okay, well, go ahead.
Are there any stats in regards to the difference in numbers of LTBI and TB numbers per person in a congregate setting of prisons or jail versus jails? That's a very good question. And it all depends on what time of, that they, do the prevalence, and, where the facility is. Is it a high risk setting? In a community that has a lot of TB versus a community that has low TB. Dr. Haley, you want to comment on that?
Yeah, exactly what you said, Ellen. And then I also want to mention there's a really nice study that was published by Lauren Lambert and some other individuals at CDC, and I think it's somewhere on my slides, hopefully, or in our references, but really did look at the U.S. TB surveillance data, and looked specifically at the different TB incidence rates and the different types of facilities. And of course, as you would expect, incidence was highest in jails. But as far as LTBI, it's very different to get good incidence, because we don't have a gold standard for diagnosis, and we don't do routine screening in the non-risk population. So it's hard to compare the positive rates for TB infection and corrections to the community. But there are some modeling studies and other things that have come out. I think we referenced one at the very beginning of the presentation, looking at that probably a quarter of individuals out in the community, especially in high incidence areas, are infected with TB. Much lower in the United States. Much lower.
And I will say, I've worked in 2 or 3 different jails, and I did prevalence in 2 of the jails, a 5,000 bed facility, and the prevalence was approximately 25% on a given day. In a 1,000 bed facility, which was a little bit lower risk, the prevalence was 20%. And so it all depends on where the facility is at, and at what day that they're doing it. Now,
also, we do have some of those, we're from, as we do better nationally, as our TB rates go down, prevalence in correctional facilities is also going to be going down. So
we would hope so, yes.
Yeah, hopefully. What other questions do you have?
Yes. The next question, are inmates required to take LTBI medication? LTBI medication is not a requirement at this point. Active disease, yes. If they have active disease, we have actually, I've been instrumental in helping to obtain court orders, even while they're incarcerated, to get them to take their TB meds. However, if it's LTBI meds, that's not a requirement. They do have a right to refuse. Now, in corrections, you want to do something a little differently. If they're like in a prison setting, if they're refusing their medications, I know a couple of prisons have actually implemented policies whereby they still come to the clinic once a month. They are still screened by a healthcare provider to make sure that they still have no symptoms. They look at all their sick calls, things like that, for at least 2 years, especially if they're a new converter. And they do education at that same time. So usually they'll take the medications. Do you agree, Dr. Haley?
Yes, I do.
The next question, I do the TST at our local county jail. Usually TSTs are done on intake, but then they're released before I can read them. Should I wait until they are there for 2 weeks or continue to do it at intake? I can tell you that the CDC guidelines for detention and correctional facilities actually states do a really good symptom screen at intake. And then if they are staying by day 7, they should have the TST or the IGRA done. The reason for that is in a local jail, not a prison, but a local jail, you're looking for active disease because at least 75% of your inmates are going to be released within 24 hours. And so you won't get the readings on a TST. And it's also doing TSTs at intake could be a security risk as well, because you have needles out there and you don't want somebody grabbing a needle or whatever. But the very important part is that symptom screen, and symptom screen is going to tell you active disease. And so you want to look at that and just make sure by day 7, you've already done the skin test and you've read it. You can get the chest x-ray. Now you can get them into the clinic so that when the clinic has to evaluate them for their health appraisal, they have all of their information there. And that information can then be looked at by the clinician and they can determine what to do with that person. Is it, whatever is happening with that person. Does that help kind of bring it together, I hope?
That's
One more.
Yeah.
I'm sorry, go ahead.
No, I said that's excellent. You really know your screening guidelines from CDC, so thank you. And again, all that is listed on your correctional toolkit, isn't it?
Yes, it is.
Okay.
Are the TB meds crushable and able to be given in applesauce? That's a great question. I'm going to let Dr. Haley I'm going to turn that one over to Dr. Haley and let her give the short answer.
So the answer is generally yes. Some of the medications really we don't want to necessarily give with a high sugar meal. However, if you're looking at a patient like this gentleman who is super sick and really needs to get his medication, and the only way you're going to get it down, it's like with children, the only way you might be able to get it down is to crush it and put it into something like applesauce. Sugar-free pudding, non-dairy pudding is also used. I think what's not advisable is trying to put it in with dairy because that can have some bigger effects on absorption. But often we have to give a little on the risk of whether or not he's going to fully get the therapy, just to make sure that he gets the therapy, if that makes sense. It may have a smaller therapeutic level, but at least he's getting it in. And then we always can check things with drug levels, which I wish that we had lots of resources and we could order drug levels to check all of our patients on how well they're doing with their TB medications and whether we're using the right doses. But unfortunately, resources aren't there, and in most patients, it's not needed.
Great. We have a couple more questions.
One more thing, Ellen. There's some great information in the Curry Guide for Drug-Resistant Tuberculosis. While that book is theoretically meant to be for drug-resistant TB, in the middle, I think it's chapter 5, every single drug used in tuberculosis, whether drug susceptible or drug resistant, is listed there, as well as whether or not something needs to be given with food, without food. There's a lot of, very practical details listed there. So when I'm not sure about something, I go to that resource and look it up, and it's a super resource for everyone.
I agree, yes. Another one by Julie Talbert. What is the initial screening when an inmate enters the correctional facility? If it includes a blood draw, could an IGRA be included in the initial screening? The initial screening depends on the correctional facility. In local jails, it could be an officer that's asking the simple questions, or it could be a nurse. Generally, it's a nurse in most of the larger facilities, and sometimes it does include a blood draw. In the prison system, and I know in the federal systems as well, it does include blood draws, and a lot of times they are doing RPRs and CBCs and HIV if the inmate requests it. But they, again, IGRA, it's people are hung up on the fact that IGRAs are very expensive. But if you think about how many chest x-rays are being done for a positive TST versus a positive IGRA, that is amazing, the differences. And so you may be saving on one end, but not on the other. So you have to actually look at your facility and maybe work with your corrections liaison in the public health area to see if that's something that you might be able to use. Again, I direct you to our corrections websites as well as CDC's website. And again, IGRAs in the population where they're foreign-born or non-U.S. born, that is critical. I think IGRAs are definitely the way to go. Another quick question, how would you recommend promoting better readings of a jail that performs 600 plus TSTs per month and reports 0 positive repeatedly in a high incidence in location? You need a TST course. Absolutely, because you should not have 0 when you're administering 600 TSTs. Your inmates are going to have at least a prevalence of 10 to 25%. So there's something going on there. They're not administering them correctly, either too deeply, or they're not reading them correctly. And we've actually done a couple of studies looking at a large jail in South Florida where we looked at how they were administering and how they were reading, and it was incorrect. We did a training down there, and people who actually were very seasoned nurses did a lot of TSTs were not able to read them correctly, and we had to go back and set up preceptors and things like that for them. So you might want to look at either going to IGRAs or going to setting up some TST courses in that particular facility. You can do a train the trainer and train others in that facility, something like that, and set up a preceptorship in that facility to watch and monitor what they're doing. And one last question, why avoid antacids with medications? Michelle Bernatsky. Dr. Haley, I'll give the short answer, but Dr. Haley will give you the in-depth answer. The short answer is the gut just isn't able to, it changes the acid in the gut. And so those antacids tend to not let you absorb the medications as well. Am I correct, Dr. Haley?
You're pretty good. That's right on in a very short description. We want to make sure that TB meds are fully absorbed to get their full effectiveness, and some, but not all, do better absorption in an acidic environment. And again, I refer you to the Curry guide to look at which ones, the quinolones in particular. Of course, we don't use those for standard TB therapy, but that's definitely don't want to give those within a couple of hours of having given antacids, calcium, or other medications like that. Excuse me. We can still take more questions, but I did want to put up a slide showing the TB Centers of Excellence for training, education, and medical consultation. SMTC is one of them, and as you can see, we cover the Southeast as well as some of our new states up in the Midwest. Our sister centers in Curry, Heartland, and Global TB Institute are wonderful resources as well, and would encourage anyone who needs assistance with patients or would like to talk through challenges, public health challenges in correctional settings, to reach out to any of the centers. I'll say Ellen is one of the top correctional experts that we have in our country, and so I'm very glad to have the chance to work with her. And you can call our hotline 1-800-4TB-INFO. and you can get some assistance from Ellen specifically, or myself, or any of the other consultants are happy to help you with challenging patients. Do we have any other questions, Ellen?
We do not, but I want to turn their attention over to the handout, the general TB and corrections resources. We do have a lot of good resources on that handout, talking about a lot of different things. And excuse me, one of the things I really want to talk about is the cost analysis of the tuberculin skin test and the QuantiFERON Gold in-tube test in a large setting in Texas. And it was interesting. I had the opportunity to consult with the physician on this. One of his issues was raised just like this person asking about the 600 TSTs and everything was zero. He found that in his QuantiFERON patients, he had a lot more positives than in the TSTs. And when we finally brought the patients in and said, well, how did they administer the TST? They never got a bleb. They were not reading it correctly. And so he went to all IGRAs because they just didn't have the expertise in that facility to do that. And it was a large facility. So that's
unfortunately, both
great
these
resource.
tests, yeah, so skin test is very difficult technically to administer and to read. And the QuantiFERON has other limitations as well. Unfortunately, this is what we have right now, but we're hoping that in the near future, there'll be better tests for diagnosis, which can be done right at the bedside, rapid results, so that we can make treatment decisions much more quickly for TB or LTBI. And so all that's underway. So we're about time to close. So Ellen, I want to thank you for participating in this with me, and all of those of you who tuned in. Really glad to see all of this interest. Please tune in for our next webinar, which is going to be in about a month on TB and opioids with Dr. Thomas Dobbs. He's one of our former consultants and an absolutely wonderful public health practitioner. I'm really looking forward to hearing his webinar, and hope that the rest of you can join us as well. Thank you all for coming, and we will be available if you need us. Thank you.
Dr. Haley, before we leave, I want to tell everybody, if you do not receive the CME evaluation within the next 2 or 3 days, please contact us at SNTC and we will send you out another one, because I know a lot of facilities can't always accept outside attachments and things. So please feel free to contact us and we'll help you.
Okay, thank you, everyone.
Thank you, everybody.